for Education and Training for the Red Cell Network for NCL. I'm also a paediatric red cell nurse specialist here at UCLH. I've asked Edith, my counterpart at Whittington, to come and do a teaching on thalassemia in childhood. So I shall hand over to you, Edith.
Okay. Hello, everyone. My name is Edith Aimiuwu. I'm based at the Whittington Hospital. I'm the Paediatric Haemoglobinopathy CNS. The topic I'm discussing today is thalassemia. So with this teaching today, we'll be able to talk about what is hemoglobin, what is thalassemia, who gets thalassemia, alpha thalassemia, beta thalassemia, and the diagnosis, treatment, and the chelation. Following this study, hopefully would have gone through this content. What is hemoglobin? Hemoglobin is the protein in the red blood cells that carries oxygen and gives it the red color. In adults, this is mostly comprised of hemoglobin A. Hemoglobin A is made up of 2 alpha chains and 2 beta chains. Alpha chains are coded for by 4 genes, 2 from each parent. Beta chains are coded for by 2 genes, 1 from each parent. This is the structure. You can see the hemoglobin which carries oxygen, the alpha, 2 alpha and 2 beta. What is thalassemia? Thalassemia is when a gene abnormality results in decreased chains being produced. This results in chronic hemolytic anemia. This also means that the usual balance of alpha to beta chains are disrupted. This contributes to further problems, like you know. And now, who gets thalassemia? In terms of thalassemia, usually prevalent in the Mediterranean, the Middle East, and the South Asia. But however, that is no longer the case. Thalassemia now has a global distribution owing to the migration of population from high prevalent regions to the Western world. This is the structure, the inheritance of the beta. You can see the beta thalassemia is an autorecessive gene, 1 gene from each parent. Then you have the alpha thalassemia. This is also very common and makes the cells paler and smaller. Size of the red blood cells depend on how many alpha chains are deleted. 1 gene deleted, usually not anemic, but smaller paler cells. If 2 genes are deleted, maybe a little bit more anemic than usual. When 3 genes are deleted, the 3 are deleted, then you have the hemoglobin H disease. Usually very anemic, but also usually well. But however, if you have the 4 genes deleted, then you refer to it as hydrops fetalis. They're usually not, they don't survive, they die before birth. Beta thalassemia. Beta thalassemia, you have what used to be referred to as a minor, which is the trait. Now I think they classify everything as whether you are transfusion dependent or non-transfusion dependent, but I'll refer to it here as minor, which is the trait, which is 1 normal gene inherited and 1 abnormal gene. Usually they are mild anemia, their cells are smaller and they're pale. While the major disease, which is the beta thalassemia, which is referred to as a transfusion dependent, they have 2 abnormal genes. They cannot make hemoglobin A. Presentation. Usually babies are born with a hemoglobin F, but this stops being produced in infancy. HbA subsequently replaces the HbF and takes over this as a main source of hemoglobin production. But in beta thalassemia major or transfusion-dependent thalassemia, no HbA is produced. Children present ill, usually from my experience, between the age of even up to 4 months. I've seen some who need a transfusion right about that time, but usually it should be between 6 months to 1 year of age. How do we diagnose beta thalassemia? Now they are part of the PND and newborn screening, when parents will be seen and discussed. Some might accept the PND while some might decline it. But however, for those who accept it, then this is being detected. Also, you can usually measure the red blood indices. The hemoglobin analysis will show that the red cells are hypochromia, that is microcytosis. There's increase in the reticulocyte between 5 to 10, and there's ineffective erythropoiesis as well. Also, you can further probably do more genetic testing in determining whether they are going to be transfusion dependent or non-transfusion dependent. That means you want to see their clinical phenotype. How do we manage beta thalassemia? We can manage beta thalassemia, which is the one we're discussing today, the transfusion dependent thalassemia. You can do monthly transfusion usually, but substitutes, however, it can be as little as 2 to 4 weekly, depending on the need, blood transfusion requirements. You can also treat beta thalassemia by bone marrow transplant. And more recently, like we all know, gene therapy, which we're still waiting for to be on the NHS. How do we decide to start transfusion on this group of children, especially the newborn when they're born, or not the ones that are transferred from other areas, but the babies, the newborn babies when they're born when we've diagnosed them with thalassemia, beta thalassemia? How do we now decide they require transfusion? You do the following things. When we see them at the Whittington Hospital from birth, when they have been seen by the counselors in the community, or probably directly referred from following PND, we do a lot of discussion. We book them into our clinic, and in the clinic we have the pediatrician, the hematologist, myself, the specialist nurse, and every other person who probably registers as well, who wants to sit in, and we discuss further about what thalassemia is. We explain to the parents, give all the information, and answer all their questions. But in this case, it's usually followed up by closely watching this baby. It's more of, I refer to it as supportive watchful wait, where we're waiting and supporting them at the same time through education and close monitoring as well. During this period of waiting, we monitor closely the height, the weight, activity level. Is this child achieving their milestones? The growth. Are there any facial changes yet? And also during examination, what is the degree of hepatosplenomegaly? Is the spleen enlarging? What size is it? And these are recorded closely in the chart, so that we can look at it and trace it. There's also serial HB checks at intervals, and these are noted. What is the level? What levels are there at that time? I have seen a child where I had to see this child every 4 weeks, monitoring this blood, the HB, just to make sure it was okay, because we didn't know the exact phenotype at that time. We're waiting for results from the DNA screening that we did. The decision to start transfusion is usually done when we now look at, is there poor growth? What is the growth? Are they meeting their center, or are they decreasing from their center, their center of weight and height? Is there failure to thrive? Are they eating well? Is there lack of eating? Are they sleepy? Those signs of anemia, we watch for it. We're watching closely for it. and subsequently the complications from excessive intermedullary hematopoiesis, which means we can detect that by facial changes. What is their facial change? Is there busting? Is there busting of the forehead or the cheekbones? And this carries on, and this varies. The time you will require this might vary from child to child, from 4 months to 9 months of age. The decision to start transfusion is usually made when we now do a blood test and the HB is less than 70 grams on 2 separate occasions, probably 2 weeks apart as well. But we have to exclude that there are no other viral infections, because some viral infection could sort of crash the hemoglobin level. So we need to exclude all that, treat infections. And if the HB is persistently below 70 on 2 separate occasions, then we'll do a transfusion. Then that decision is made. What is the aim of blood transfusion? What do we aim for when we transfuse these children? We want to aim for good growth and development. We want to ensure that they have good energy levels, enough blood to sufficiently suppress their intra and extramedullary hematopoiesis. Then we want to aim for a pre-transfusion hemoglobin of 95 to 105 grams per liter, because with this HB, then they are able to live a normal life, because you want to optimize their transfusion. When we're doing transfusion, what do we aim for? We want to aim for safe transfusion, and this can only take place by close blood testing. We want to cross-match each time the child is needing transfusion. The blood is collected, is tested, selected properly with the phenotyping we've done in the past. The lab, I often would contact the lab that we have a newborn coming in for transfusion, thalassaemia, what do we need? And I often request all their requirements with the blood bank so that they can selectively give me the appropriate blood to meet the quality and safety regulations that has been established. And transfusion should be administered by staff trained in blood transfusion. We also have, we let the family know, we obtain consent, give all the leaflet, tell them how the process is on the ward or wherever they are having the transfusion. And this transfusion should not occur anywhere. It should occur in a space where there is a good system that is hemovigilance structure is in place, where they can note any problem, any reaction. The staff should be aware and should be well trained to look out for those things. What blood do we require? Before transfusion is started, like I said, we go to the blood bank. We request for the blood should be ABO compatible, resource C, D, E, and KEL compatible. Because most times with chronic transfusion, they can develop alloimmunization. And the full cross-match at each time, like I mentioned before, the blood should not exceed 10 to 14 days old. It could be probably newer, but however, it shouldn't be more than 14 days old blood. It should be CMV compatible. And probably not on this slide, I often will require sometimes, if I know in the future they might require a bone marrow transplant, I often will require a blood that is a CMV negative as well. Or also, even at some instances, require radiated blood if I know they're going to go for a transplant. Prior to transfusion, now we have to make sure they have hepatitis B, immune. We do serology. Nowadays, the hepatitis B immunization is part of the newborn screening. Otherwise, you need to check to make sure they are immune. And if they are not immune, you want to give them a booster of a hepatitis B injection to ensure that their antibodies is greater than 100. What is the process of blood transfusion? Transfusion should be done in a designated unit. Staff should be able to take time to answer questions that will be asked by the parents and all that. They should take time to answer all the questions. They shouldn't be in a rush. There should be a specialist nurse who sort of coordinates the care of these children with thalassemia, makes the arrangements of the cross-match, ensures when making these arrangements, it sort of fits with the family system, because it's a chronic illness. You need to fit it into their system. There's no point booking a blood transfusion when you know it's going to disrupt the whole family. So from the beginning, you liaise with the parents, see what is convenient for everyone, both the system, the units, and the parents, then arrange a blood transfusion for those days. Cannulation should be done by experienced staff. Prescription of blood by medical team, or the specialist nurse like myself. I'm a blood prescriber, and often we prescribe the blood using the calculation. In pediatrics, we do prescribe blood in mils, and I've just put down the slide what it should be. Desired hemoglobin minus the present hemoglobin times 0.4. I know some centers might use 0.3, but generally is usually 15 to 20 mils per kg regularly every 4 weeks. Required volume should be prescribed in mils. I've mentioned that. And the aim of the transfusion is to aim for the hemoglobin to be around about 135 grams to 140 grams per liter. However, you would not transfuse more than 40 grams at a time. So if the child's hemoglobin is 65, however, you're not going to take it straight to 140. You need to transfuse 40 grams at a time in increments. Then while having the transfusion, the staff should be able to observe closely, and the observations should be done according to the trust policy on blood transfusion, monitoring baseline observation during transfusion and post-transfusion, and noting for any signs of reaction. And if there's any signs of reaction, this should be done accordingly, according to the policy, stopping the blood, getting everyone informed, and treating accordingly. We've talked a lot about transfusion. What are the side effects of transfusion? In transfusion, the main complications could be iron overload, virus transmission, but in England, for example, that is often not the case because the blood is well screened, is leukocyte depleted. But however, those are the side effects that could occur. Then there's allo-antibody formation. Side effects are complications. We know with thalassemia, blood transfusion is very good, but however, is the side effects that occurs following blood transfusion. So we tend to treat the side effect, then treat another side effects of that. I think biggest problem with thalassemia is the side effects of treatment. The second biggest problem is the side effects of the treatment of the side effects. Then you have osteoporosis, then extramedullary hematopoiesis. Iron overload. The iron overload, the impact on the child or depends on the site of iron, where the iron is deposited. Endocrine organ could be affected, resulting in diabetes, infertility, hypothyroidism. If it's in the heart, you can have palpitation, arrhythmias, and iron overload in the heart could result in death. Then also in the liver can result in liver cirrhosis and carcinoma. However, I don't think this occurs so suddenly in a newborn, newly transfused, but over time. So we need to be quite vigilant in looking out for iron overload and managing that effectively. How do we get rid of the iron? We get rid of the iron through chelation therapy, which removes iron into the urine and into the feces. And this could be monotherapy or combination. Monotherapy in the sense that you're just using one chelator, one chelation drug like deferoxamine, or you can do combination drugs such as deferoxamine and deferoxarox, or deferiprone and deferoxamine. what is the treatment? The deferoxamine has been in use for so long, and that can be done as a subcutaneous infusion or as an intravenous infusion in adults with severe iron overloading. And the dose range should be between 20 to 50 milligram per kilogram. However, if you're just starting a child with unchelation, not yet established iron loading, you want to start at a lower range. But however, from my experience, we tend to use about 40 milligram per kilogram. This drug is expensive, like we know, and we can infuse this medication at home over 8 to 13 hours as five nights a week, in some cases 7 nights a week. It could be toxic if we overchelate, and you have the oral chelators such as desferoxerox, known as XJADE. XJADE usually can go up to 28 milligram per kilo, but from experience, I think by the time you're using 14 milligram per kilogram or to 22, I think that is often enough if there's good compliance in taking the medication. Then you have the deferiprone, and deferiprone also can be used, maximum daily dose of 100 milligram per kilogram per day in 3 divided doses. All these medications, they all have their own side effects and complications, so we need to be mindful in treating it and educate the parents on how this should be used. I know a lot of, with the desferoxerols, often you have side effects like abdominal symptoms, GIT complications, GIT bleed. So you need to be, although the manufacturer says give XJADE on an empty stomach, but with our experience on our units, we tend to say give it with food because of the impact on the GIT. So they can have the food and have the medication. With that, we find we have less GIT symptoms, but it doesn't mean it is not in existence. But if you just be mindful of that. Then the deferiprone also can result in neutropenia. So you need to be aware, asking the questions, ensuring there is no abdominal pain, and looking out for all the abdominal symptoms that could be there. And if there is, then you need to review your treatment. This is sort of like a picture of a child inserting the desferoxamine, which has been in use. However, we find a lot of parents and children don't like it. But it is a good treatment that has been in use for a long time. We use it by putting the thalassate with the infusion to run overnight. Why the XJ, the desferoxerox has only been started since 2006, but it's very effective if there are good compliance. Chelator, in starting chelation with a child or a newborn child that has started transfusion, you often want to, they don't chelate, they don't accumulate iron for a long period, probably up to 1 year transfusion. So this needs to be monitored carefully. We do ferritin level, serum ferritin level. In monitoring the serum ferritin level, you want to get 3 consecutive serum ferritin of about 1,000 before you start chelation. And in starting before 1 year, because the oral chelator says from 2 years old, which means the baby will have to start on desferoxamine. So there's a lot of education on desferoxamine, how to use it, and we teach parents and sign them off to use it at home. But that is the monitoring you have to do. 3 consecutive ferritin before you decide to start chelator. Ongoing monitoring of a child with thalassaemia. What do? We tend to ask for clinic attendance 6 to 9 monthly in our joint hematology clinic, where we have the hematologist, the pediatrician, and this clinical nurse specialist. During that clinic, we also continue to monitor their growth, monitor their activities. We discuss school with them. How are they in school? Are they able to catch up? Because you want to ensure that your transfusion is optimal. because the children can tell you, oh, no, I'm not catching up. 3 weeks, probably 3 weeks after my transfusion, I get too tired. I can't catch up in school. So you can review that and see, do they need more? We also do a trend of the hemoglobin, monthly hemoglobin level. We have a flow chart that we document. Then we can consistently see what is the level. Are they persistently lower than what it should be? If that is the case and they are on 4 weekly transfusion, you want to increase that frequency. The frequency should be decreased. If they are on 4 weekly and they are not being optimized in transfusion, we can reduce that to 3 weekly. In doing that, you might reduce the blood volume as well, because all you want to do is reduce the frequency, calculate, and ensure that they're having enough. So most times we can do 3 weekly for some months, then they catch up before we go back to the 4 weekly. So in that clinic, that is where all that is reviewed. The hematologist will calculate what is the iron loading, the daily iron loading, and compare it and see if we need to either review their chelators or not. Yearly calculation of blood we do in our service. After 1 year, every year we do an annual review where we calculate how much blood they are receiving. If the blood requirement is very high or exceeding 220, then we have to screen. We can screen, then look at their spleen, ensure that the spleen is not big enough. However, we haven't got any child with sickle cell, with thalassaemia receiving splenectomy in our service, except if they've been transferred from other units, because that might be a sign that they might need one. But however, we haven't got that in our units. But we monitor that carefully. What is the total yearly blood volume that they receive? Then we monitor for puberty as well. We refer the boys at the age of 14 if there is any delay in puberty, while the girls are referred at the age of 13 to the endocrine team. We have the endocrine team based in our hospital as well, where they can be seen and monitored. If there is any delay subsequent, if they find following their wrist x-ray or other screening and results that they need any intervention, they usually treated with testosterone, which we give every 4 weeks or 3 to 4 weeks as suggest or prescribed by the endocrinologist. Usually we often don't, I think probably 1 or 2 from our caseload, but it's not a routine. We also do in this clinic, or in our service, we monitor yearly ferric scan. Ferric scan is to determine the amount of iron loading in the liver. We also do 1 to 2 yearly T2 star scan for children above 8 to 10 years old that can hold their breaths, to see what is the iron load, if there's any iron loading in the liver or in the heart as well. We often accept a range of less than 5 is our range for the ferric scan, less than 5 milligram per gram dry weight. However, it's still acceptable to be up to 7. Where if it is exceeding 7 milligram per gram dry weight, we often will probably do a lot of education, discussing with the parents, ensuring compliance of taking the medication. Then we do yearly eye check and hearing test, especially when on desferoxamine. Presently in our service, we don't have any on desferoxamine, but we do yearly eye check and hearing test. We also do yearly serology just to ensure that their serology is still intact in terms of Hep B, Hep C, and that we just ensure they are all intact. We do 4 weekly ALT. This is done along with the blood test, the pre-transfusion blood test. We check their ALT, we check their creatinine, and we dip urine for protein, just to ensure we know that the chelators such as XJ could be quite toxic, so we need to monitor that closely. If those levels are abnormal in terms of the ALT, we often can either reduce the dose of the chelator such as XJ and monitor that closely. But depending on results, then we act accordingly. Then we have regular discussion on compliance and adhesion. This often with the older children, because with the parents, they're quite good, they give the medication and they take it. But with the young adults, because they feel in terms of independence, they want to be independent, the parents tend to leave them to do it, which is good. But however, we have to ensure compliance. A lot of discussion daily when we see them in clinic. We go through the result. I print out the result and go through the results with the parents. This is what the ferritin is now. This is what it should be, and all of that. So that they will have a visual chart in front of them and that they can use in monitoring. Or even along with the hemoglobin, I often give them all the results. This is what your hemoglobin is. This is where we want it to be. Or this is your ferritin. This is what we want your ferritin to be. And they can go along. This is why I've prescribed this dose. This is why it's important to do it. We had a child with that came from other country where the ferritin and the T2 star scan was so high. There was a cardiac loading, but in discussion, I realized that the child was not really taking the drug, was throwing it away until the emphasis was made that this is what the problem is. Then the child realized and is quite compliant, and those levels have normalized at this time. Then I think that is it. Any questions will be, I really want any questions, anything, any discussion. I think that's the end of my lecture or presentation. Feel free to ask questions or whatever we don't know.
Oh, looks like we have a raised hand from Indy.
Okay, I think I've got one hand up. Yes.
Hi, Edith. Thanks for that. I'm a pediatric hematologist
Sorry,
at Cardiff. You can't hear me?
Oh.
Hello?
Oh,
can you hear me?
Can you hear me?
I can hear you.
I can't hear you. Let's see what's going on in my pen.
I can hear you, Indy, so I'm not sure if it's Edith's side. Okay.
Do you want me to carry on or what?
Give Edith 1 minute and see.
Yes, I can hear now. I can hear you now.
Okay. Hi, Edith. Thanks for your talk. I'm a pediatric hematologist at Cardiff.
Yes.
You know, as hematologists, we also have to weigh up non-wastage of blood. So obviously we do calculate in mils, but then out here we sort of try and round up so that we're not wasting any blood. What do you do in that regard at your unit?
What we do, we calculate in mils, but however, if the amount of blood, for example, if the child is going to receive 350 and the unit have been given is 280, I would not open another unit for it because you don't want to expose them to another complication of using another unit. But however, if I want more, what I use as my discretion is if I need more than 100 mils, then I will open another unit.
Thank you.
Yeah.
Yeah, I have to agree. That's what I tend to do as well over here. Although quite a few of my families have strong opinions about that.
Okay.
You've got another hand up, I believe.
Yeah, I think the parents they often will say, oh, I've not had enough, but I do explain to them that you don't want to be exposed to the exposure of another unit that can cause a lot of the alloimmunization, and they do understand. And I tell them at the end of the year, if I round up, you might find that on the average, they've received what they should have. Okay, yes, please.
Hi, yeah, I'm Michelle Cummins from Bristol. Thanks for your talk. So I know you've said you've not got any patients on desferrioxamine, so you may or may not be able to answer this. So are most centres now using balloon infusers or are they using pumps? And if they're using balloon infusers, are they having problems with the volume that you need to give to a small child to be able to infuse? Because we've had a child recently that we wanted to start who's a 6-year-old, and I think the minimum volume by a balloon infuser was 4 mils an hour, which is quite a lot. But equally, we've had big problems at actually getting our hands on pumps and the trust supporting keeping, the sort of maintenance of pumps. And again, we haven't used desferrioxamine for a long time. This was a child who came from abroad. So we've sort of ran into kind of difficulties getting her started. So I just thought I'd see what people thought.
Yeah. What we do, we've had children on pumps, and it's just that at the moment we don't have any presently on desferrioxamine, but we've been using that for a long time. We used to use the T34 pump. I don't know if you know about the T34 pump. There is a pump. In the past, they had these smaller ones which were discontinued. Then we now have the T34 pump, which we had to get our service to get. It's usually used within the whole hospital. The T34 pump you can infuse. What we did, we teach the parents on how to use it. We give them the T34 pump to take home, and they make up this drug accordingly and draw up what they want. And with the T34 pump, you can infuse the drug 1 ml an hour, but it depends on what. So, but we also have, no matter even it doesn't matter the age of the child with the infuser, with the infusion, because the volume is so high, or is a lot, because they mix it in 60 mils, I think, and usually no matter what, the child can never finish it. So it's a problem. I think when that came up, before we used to have the balloon infuser, but now they've changed it to the infusion. The balloon infuser was better, but they now discontinued that, and they've now used the infusion, which has been quite problematic, depending on the site. But I would say, if you want, you can get your hospital to get a T34 pump, which is quite available, and you can get that to the parents and teach the parents how to use it. It's quite straightforward in using it.
Okay, that's really helpful. So essentially, there isn't really any balloon infusers that can give as small a volume as a pump infuser. So we've got to go and try and source a pump, which actually is easier said than done when you kind of then have to enter into contracts of maintenance of pumps and that sort of stuff. But
what we did, we bought it, and we got our medical physicists to agree with the manufacturers that the maintenance will be done by them. And so on a yearly basis, we just take it back to our medical physicists, who contacts them, and it is done. I don't think it was quite expensive when we did buy it, because we bought it from charitable fund, and bought the pump for us that we had to use. But that might be a way forward to get.
Okay, that's really helpful.
The diffuser is always a problem.
Yeah, I have to admit, over at UCLH, the smallest dose we do is 500 milligrams, and that's over 8 hours, which works out about 6 mils an hour. We did look at trying to get hold of one of those pumps, but we were pretty much hit a brick wall every time trying to get one, because we used to have the I think it's before my time, the Gravesby pump.
No, those ones were cancelled a long time ago.
And then there's the chrono pumps, which I don't know if the T34 is a chrono pump, but so you've just gone back to using balloon infusers and accepting 6 mils an hour, have you, or in your slightly older children?
I mean, the only reason we did that is because the child was over the age of 2, so it wasn't a license for Exjade. But their creatinine was just all over the place until they were a little bit older, and then it stabilized, and we've got them off the pumps now. But even trying to find the 500 milligram pumps was a bit of a nightmare. Through our own hospital at home company that we use, we had to do a hunt trying to find someone who will make it 500.
You mean a balloon?
The balloons. We have I think they're Baxter Easy Flows.
And so that child tolerated 6 mils an hour, did they? Subcut?
Really? Was it finishing? Most times they don't finish it, though. You just find that it's just swollen. It's sort of the site
that they
give up. The site is swollen, and they don't really finish it.
I mean, majority of the times it was fine, but the odd pump, 1 or 2 of each 2-week delivery batch they had, wouldn't finish. Or the balloon itself was malfunctioning, or the pump.
Okay, well, that's useful. So I guess this child is actually probably not going to be with us for much longer, but we could, I guess, trial the 4 mils an hour and see how she got on. And then if she didn't, then we could go purchasing a pump, or just look at buying a pump, I guess.
Okay.
Yeah. Thank you.
Thank you. Okay. Any
Just
questions
one
for
question from me, Edith, actually.
Okay.
Seeing as you're my senior, many more years than me.
No, I don't.
No, I've been told you're the oracle.
Oh
And
my
there's always
God.
raving about you and all that. One of the challenges I've had recently is, I don't know if you have any patients at the Whittington that parents are also transfusion dependent.
Yes, we do. Mhm.
Trying to do this whole freshness of blood thing. Now we're saying 2 weeks is fine because we went through that shortage and everything like that. And quite a few of the parents are hanging on to the 7-day
I think
rule.
no, I think the 7 probably discuss with your blood bank. Our blood bank has always been 10 to 14 days as a rule, but for sickle cell they say 7 days, or 3 days if it's for 3 days freshness if for exchange for sickle cell, and 7 days for sickle cell patients. But the thalassemics, they've always been, to my knowledge, even with our blood bank, has always been 10 to 14 days, minus the shortage of blood.
So maybe ours did it for a time and then they've sort of hung on to that idea, and it's been tricky to get them off of that.
But with sickle cell, it's always 7 days. It should be 7 days, or the fresher the better.
Amazing, thank you. Oh, another question for you, Edith, it looks like.
No, it was really, can you hear me?
I can hear you.
Yeah, our blood transfusions will happily do 7 days. They haven't gone to 10 days at all. All our blood comes at 7 days. For all our thals. I think must be quite lucky there then.
Yeah, you're lucky then.
I think I would have refused it if it was 2 weeks. So am I just being lucky then?
Yes, definitely. I think from our blood bank from beginning, when you're discussing, I think the write-up was that with sickle cell it was 7, but with TAR they can accept 10 to 14 days. If it's fresher, fine enough, if that's what they get you. But however, in terms of what you can accept as your optimum, shouldn't be older than 14 days.
Thank you very much.
Okay.
I think from our point of view, it was 7 days generally, and then once we had one Amber Alert for the blood shortages last year, they changed the policy to make it 14 days, and now we're just staying at that.
Yeah, I think you people have been lucky, but with us from beginning, it's always been all the 10 to 14 days. But if it's fresh, I don't question if they give me a 3-day old, but I will question if they give me more than 2 weeks. Okay, is that all? No, it's finished.
I was going to say, any other questions for Edith before we let it go?
Okay. I think that is it for now.
Thank you very much, Edith.
You're welcome. Thank you. Thanks. Bye, everyone.
Thank you very much. Thank you.
Thank you.
Bye-bye.
Bye.
Thanks. Bye.
Bye.
Thank you.
Bye. Bye.